what we observe is that people look more relaxed when the right voices are in the room.
Interesting.
Can become agitated when the wrong voices are in the room. That people, deeply unconscious people, sometimes synchronize their breathing to the rhythm of music that's playing in the room. Wow. So the science is still very young, and our observations are that the brain is hearing in a receptive sort of way. So we tell families to keep talking.
Thanks so much for coming on, Kathryn. So just to kick off, I wondered if you could just talk a little bit about palliative care and hospices in general, because I know for anyone listening that hasn't lost anybody, the words palliative care and hospice kind of has quite a negative connotation. You know, it's kind of associated with end of life and, you know, there's less hope and stuff like that. But I think it's probably more of a positive thing than that. Could you talk a little bit about that?
Yeah, that's a great way to start, isn't it? Because the palliative care community will kill me if I don't say that palliative care is not about dying. And that's the thing that surprises people. Palliative care is about living, and it's about living the best you can. And so that's about minimising your symptom burden, optimising your quality of living, helping you sort out difficulties with relationships or paying your bills or care for your pets or, you know, whatever is important to you at this stage in your life. And the best way of relieving the burden of somebody's symptoms is to cure the illness they've got, right? So people whose illnesses can be cured very often don't need the support of palliative care services because their symptoms are relieved by treating their illness, making it go away. But if your illness can't be cured, then there's a long time between, I'm sorry, this is not a curable illness anymore. For lots of different illnesses, you know, we traditionally think of cancer, but heart disease, liver disease, lung disease, there's a variety of things that we can go with in the end. And there's a long time between that becoming no longer a curable disease and a condition that's actually going to kill you next week. So we've got to think about all of that time of living and what do you do to enable that person to carry on being as much the captain of their own ship as they want to be, comfortable, free from symptoms, not worrying about things unduly. Of course, people who have incurable illnesses will be concerned about what's going to happen in the future, and that's something I think we need to be better at talking about. But palliative care is all about quality of life and living well. The difficulty, the mix-up is that many of the patients that we meet, because they're doctors and nurses, or they themselves or their families thought, oh no, palliative care, that's only about dying, we won't see them yet. Oh no, they're not ready for palliative care yet. They're not ready yet, which is a real bugbear for us in palliative care. We meet people really late in their illnesses. And we think, you know, if we'd met you 6 months ago, 9 months ago, you could have had 6 months, 9 months without this horrible breathlessness you've got, or this awful pain, or this change in mobility that you've been suffering from. Never mind, we'll do what we can from now. But what a shame that your family had to believe you were dying before they would let us help you to feel better. So palliative care is about feeling better, and everybody should be demanding it as early as possible.
So it's interesting to know that an earlier intervention would be very beneficial.
Am I right in thinking that you can actually request palliative care and it's an option and not something that's just bestowed upon you when the doctor thinks is the right timing?
Okay, so you can request an opinion from a specialist in anything in the National Health Service. So if you're really worried about the way your heart disease is going and your GP's doing their best, but you'd like to see a heart specialist, you can request that. And the heart specialist might look at you and say, well, you know what, everything your GP is doing is absolutely fine, we've got nothing to add, we're done here. If you're worried again or if things escalate, I'll happily see you. So palliative care might do the same thing. Somebody might be seen, and what we'll do is say, do you know what, your GP, your community nursing team, or your heart failure specialist or your cancer specialist team, they're doing a great job here, and actually we haven't got a great deal to add at the moment. However, if things change, then we're very happy to see you again. So sometimes just meeting your local palliative care team, just to see whether you like the cut of their jib, You know, that could be an interesting way of approaching that. So people dip in and out of palliative care. My job was, for the last 10 years of my working life, was with a hospital palliative care team. So it was ward consultations, seeing people while they were in hospital, giving them back to community palliative care services, perhaps when they went home, or sorting them out while they were in hospital under the care of a surgeon, a physician, geriatrician, whatever. And so they would go home without the symptom burden that they'd have when they came in, might not need to see palliative care services for a while. So it's really about using us as we're needed. It's not just once we've got you, you've got to die.
Yeah.
And that, you know, you're not obliged to die if you see the palliative care team, and that's really important to know.
You don't have to die. I remember, I'm just thinking back, like when I've been in hospitals, like visiting loved ones, and the palliative care ward was always very, very elderly people, all unconscious. Like the whole ward was unconscious people. And so in my mind, I was thinking, well, you know, my mum or whoever it might be won't be on that ward until it's the very, very end. And then what good can you really do then? Because I'd imagine it would just be like plumping pillows and like pumping you full of medicine and, you know, kind of making you slightly less in pain. But it sounds like it's more about a lifestyle thing than that.
I think we've got a problem of mixing up the expressions. So we've started to use palliative care to mean dying. A ward in which everybody is unconscious and no longer eating and drinking and very close to death. That is not palliative care. That is ordinary dying, about which I hope we're going to talk a bit in a minute.
Yeah.
But when you go to see a specialist palliative care unit, and our technical term for those is hospices, you will meet people walking around, testing out their new wheelchair, working out whether they can walk properly on their hip replacement, doing their workout in the physio gym, working out how far they can walk now that their pain is better or their breathlessness has been eased. You will meet people who are sitting, learning painting. So we need to get you in to give some lessons.
Yeah.
Or they're listening, they're sitting learning crafts in a day centre where people who think, oh, that's it now, there's nothing left that's new for me, are going on new micro adventures as we're harnessing their creativity, their thoughtfulness, the things they want to do. And, you know, if before their pleasure was walking up a mountain and they're too breathless or their muscles aren't strong enough to do that anymore, what is it about walking up a mountain that brings you joy? Can we bring that joy in some way into your life through photography, through writing, through painting, through crafting? So these are people who are still looking for the joy in life. And because we get to know them well and they come in and out and in and out, there will be, in, you know, maybe a 20-bedded hospice, there'll be a few people who are actually actively now dying, like those people in the hospital ward you described, who are now deeply unconscious. Their families know what's going on. They're visiting, they're sitting around them. They can still hear, so we're asking families to keep talking so those beloved familiar voices are still in the room. But they usually haven't come there because they're dying. They first came to the hospice because there was a really tricky physical symptom, emotional, psychological symptom, something going on in the family that needed that kind of the catalyst of a different place and a different team around you for a while to be able to ease that difficulty. And they've got to know us, and over a period of time, maybe they'll die there too. But we've got to get dying right everywhere. Only 5% of us will die in a hospice. But 100% of us will die.
Yeah, and I feel like there's probably a lot of fear around that. Just that 100% of us will die. There's still part of me when I hear that phrase that thinks, not me. No, never. So yeah, maybe we can start by talking a little bit about that, about death. Well, you know, why are we so scared of it? What's there to be scared of, really? What's it like? You know, I'd imagine seen a lot of it. And I'd imagine it's not quite as the films and TV shows and stuff kind of depict it to be.
Hollywood death, the EastEnders death.
Yeah.
So the soap opera's got quite a lot to answer for, really. And something that people might find interesting to know about is that each of our soap operas in the UK, they produce a little YouTube video at the end of the season of the deaths.
Wow, really?
So you can go and watch, and you can see that Albert Square has got a more dangerous place to live. over the decades. It's so high. Yeah, it's a really
What about
bad
Midsummer
postcode.
Murders? Midsummer Murders is, ridiculous.
So, so there's something about using dying as a plot device. And it used to get me very, very annoyed because the dying would always be ridiculous and very, very badly done. And I was whinging on to, I'm having a senior moment now, Carrie-Ad Lloyd. I was whinging on to Carrie-Ad Lloyd.
Yeah.
We were recording the grief cast. And saying, these deaths are just so badly written. And because she's a writer, she's coming at it from a completely different perspective. She said to me, but it's not about the death, is it? It's not about the dying person. It's a plot device so that the other characters get a kind of shake up and it moves their storylines along. And I'm going, duh, why did I never see that? So TV deaths, generally nothing to do with ordinary dying. And the really noble exception was Coronation Street did a really great storyline about a young mum dying of a gynae cancer, probably about 6 years ago.
Okay.
She was called Siobhan or Sinead.
Do you watch EastEnders?
No, Coronation Street.
Oh, sorry. Same thing, aren't they? They're all merged into one in my mind.
He did this really, really well. And all of the things that people really are concerned about, that she had a child who was very small, too small probably to remember her by the time they were growing up. She wasn't with the child's father, but she wanted her current partner to be able to bring the baby up. She wanted to stay at home, and eventually it was too difficult for her family to keep her at home, and they had to think about where she might be instead. She was worried about taking her painkillers. Somebody talked to her about her painkillers. They had fantastic palliative care support for their script writers. It was obvious that they were being expertly guided. And I've written and spoken quite a lot about ordinary dying. So as she's dying, I don't watch it either. My phone is pinging hot with people going, "Did you write this? This is like one of your stories." And I go, no, I didn't write this. But if they've got expert advice from people who've seen a lot of dying, it will look like ordinary dying, which is what I'm paying witness to as well. And how fantastic that they did it so well. So should we talk a little bit about ordinary dying?
Yes, please.
So it's the big scary thing, and it's a thing that we've almost given the language away about now. When we've been brave, aren't we? We're saying dying instead of passing or reaching the end. And I'm really concerned that if we don't use our D words, then we won't be able to talk to each other about what this stuff is really about. So it doesn't seem to matter what the illness is that a person is dying from. Towards the very end of our lives, the trajectory is very similar. And the first thing that happens, and we were having a conversation with somebody else just now about exactly this, the first thing that happens is the person gets more tired. It's as though we're running out of energy. And so doing less exhausts us more, and we need more recuperation time. And to start off with, that looks like sitting down more, going out less, not walking up a mountain, just going sitting in the car park while the family walk up the mountain. But gradually it looks like not going out of the house, or deciding whether to use your energy to get out of your pyjamas or to do something else with the day instead. Sitting down more, falling asleep more. And the sleep is really important because it's the sleep that recharges people's energy batteries. And it's a bit like one of those old mobile phones, where the battery just doesn't hold its charge. So you go for your sleep, you put yourself on your charger, you wake up and you do one thing, and you need to go back to sleep again. So gradually what we see as time goes by is people are sleeping for longer and longer, and they're awake for shorter and shorter. But if their illness isn't affecting their actual brain, and if they're not on drugs that are changing their thinking in any way, then when they're awake, they're just their normal selves. Same sense of humour, still pleased to see the people they love, still not pleased to see the people they're not very fond of. It's just normal.
Yeah.
And family life around it can be normal, except that, of course, they've got additional needs because they're spending more time in bed. Maybe they struggle to get to the toilet in time. So maybe there might be accidents, maybe there might be extra laundry, extra clothes to wash. So if you've got a family near you that's doing this kind of work to look after somebody, offering to take in laundry for them, offering to do supermarket runs, things like that can be a really practical, helpful way of supporting people. So as time goes by, people gradually become less and less likely to be awake, until they are not asleep, but actually unconscious all of the time. And it's really important people understand that it's not like going to sleep. If you're well enough to feel tired enough to need a nap, you're well enough to wake up at the other end of the nap. Falling into unconsciousness isn't something that people are aware of.
I see.
So you might find a person is deeply asleep. Oh, sorry, you've arrived and Dad's asleep. I'll wake him up for you. He's sleeping a lot now. Try and wake Dad up. Can't wake him up. That's really weird. So give him a cup of tea. Dad's still not awake. Okay. When Dad eventually wakes up, we say, we tried so hard to wake you up when Uncle Billy came. And Dad's saying, oh, you can't have tried hard enough because I was just asleep. But actually, he wasn't just asleep. He was unconscious for that period of time. He dipped much deeper than sleep. But his sense of it was, I fell asleep, I woke up again, and nothing happened in the middle. So we don't have a sense of being unconscious. I suppose the clue is in the name. So it's not a frightening place. It's not a space that you go to that's weird. It's just a space in which there is no awareness.
Interesting. Like physiologically, what's the difference between being asleep and being unconscious? Like you're still breathing, you're not getting any brain damage or anything like that.
No, it's what your brain is doing that's different though. And if you were to put EEG probes on people, then you would see, you know, that we've got awake brain waves at the moment, and there are kind of daydreaming brain waves of the next phase down. So, you know, when you manage to sit and talk to somebody, but they've talked for so long that you're amazing, your brain waves are actually changing at that point.
Yeah.
And there are different brainwaves for the different phases of sleep. So deep sleep is different from dreaming sleep, for example.
Right.
And then unconsciousness is different again. So if we were to put people into machines that would measure or put little electrodes on their heads, we'd be able to see that.
Would just be a flat line then?
So that now we're getting into real brain neurophysiology, and I'm not an expert.
I don't know why I care so much. I'm like, what exactly do these brainwaves look like?
No, but what we know is that there are levels of unconsciousness that when people come back round from them, they don't report having been experiencing unpleasant, difficult things. So it's deeper than dreaming. You're not in some nightmare place that you can't wake up from.
And for the patient, you know, or the person who's going into these deep unconscious periods, is that a comfort for them to think that this is actually what death looks like?
That's interesting. Well, so usually this is something that I would talk to my patients about. We talk about unconsciousness, and so, you know, in advance. So towards the very end of their lives, they'll be saying, "Oh, it's that thing that you said." You know, it must have been, I just didn't know any of that had happened. And so you can visit people and say, I told my wife to wake me up when the grandchildren came. And she's saying, well, I tried really hard. So there's this period, it's not a very long period, where people are dipping in and out of sleep and so deeply that they go into unconsciousness, and then eventually they don't waken and they just go into deeper and deeper unconsciousness. Now, the thing about that is unusual for the rest of us is we don't normally see people who are really, really deeply unconscious, because that is something that maybe happens after you've had your brain injured in a traffic accident, or you've had a big stroke or something like that, and that would be a medical emergency. And because one of the things that happens is that your breathing starts to change and to be not as efficient, if you were really sick and you were unconscious, you'd be in an intensive care unit, you'd be on a ventilator, and we wouldn't see the natural unconscious state that we allow dying people to be in. So we only see it at the edge of death. And so the completely unconscious brain is still doing a few things. It's still hearing. Now that's really, really interesting. We thought that for a long time. And our evidence really came from reports from people who'd had brain injuries who were unconscious in intensive care units, who then reported conversations that they'd heard around their bed from the staff and from their friends when they eventually recovered. So when you see nurses dealing with an unconscious person, they talk to them the whole time. They explain everything they're going to do before they move them, while they're washing them, while they're giving care. But about 4 or 5 years ago, there's a lovely piece of research came out of Canada where a group of people in a palliative care facility in Vancouver agreed to join in this study, that they would wear little electrodes on their heads, just like we were just talking about, to the very end of their lives.
Wow.
So what they were able to do was see what was happening to their brain responsivity. And what they did was to play them to unusual noises. So there wouldn't be noises that would happen in the room or that people would make. And they played these noises and they recorded their brain responses to them. And then as they gradually became more and more unconscious and right down towards the very end of their life, they carried on playing these two noises from time to time and recording their brain waves. Because these days you can do it with just tiny electrodes and some Bluetooth thing. You don't have to have your head in a scanner anymore. And what they showed was that the brain responses to these sounds were the same when they were fully conscious. They were making the same response. Now, does that mean that they can hear and make sense? We don't know. They haven't done that experiment. So if somebody's sitting holding their relative's hand and saying, I'm here, and our son is coming, but actually his wife is in labour and we don't know when the baby will be born yet, so he's going to stay with her until the baby's been born, blah, blah, blah. We don't know whether the person is hearing a noise that's comforting, because I've been hearing that noise and it is my wife's voice for years and years. My actual wife's voice speaking to me about our son and our daughter-in-law and the baby. We don't know quite what they're picking up. But what we observe is that people look more relaxed when the right voices are in the room.
Interesting.
Can become agitated when the wrong voices are in the room. That people, deeply unconscious people, sometimes synchronise their breathing to the rhythm of music that's playing in the room. Wow. So the science is still very young, and our observations are that the brain is hearing in a receptive sort of way. So we tell families to keep talking. And the other thing that the brain is still doing is it's still kick-starting our breathing cycles, but it's doing it in a really weird way. So most of the time we don't think about our breathing. And now I've said that, you're thinking about your breathing. Everybody who's listening to us is thinking about their breathing as well. But normally we don't think about our breathing, but you are actually breathing in a way that's aware that you've got a microphone just in front of your face, so that you don't blow or tick or tut into it.
It's very shallow breathing, the podcast breathing.
And when we're speaking, because we've got a microphone in front of us, we're taking a deep but carefully quiet breath, and then we're trying to take enough breath to get a whole sensible phrase out before we pause and take the next breath for the next phrase. Right, so we don't really think about our breathing, but we do manage it. At the very end of life, when somebody's deeply unconscious, none of that is happening, and the brain kicks into very rudimentary kind of cycles, reflex cycles of breathing that move backwards and forwards between very deep breaths that are they're drawing breath sometimes through the vocal cords, so it sounds noisy. And families, if they don't know that this is just a reflex, unconscious breath, might think this person is sighing or groaning or trying to talk. So it's really important that we remember this stuff. We knew it once and we've forgotten it, and we need to reclaim it. So deep breathing that could be noisy, that gradually gets shallower and shallower and shallower.
Because you hear about like the death rattle, don't you? People always say, is that what that is?
Well, it's a little bit about that. So partly there's this kind of deep to shallow and back again, and partly there's fast breathing to slow breathing and back again. So you can imagine, as you kind of mix and match, that there's phases where it's fast but it's shallow, and that could look like somebody who was really working hard to breathe, really gasping to breathe. And if you didn't know, and if nobody tells you, you would look at that person and think, oh, that's really hard work. They're really, really breathless. Or if it's in that kind of very slow phase where it's noisy, somebody needs to tell you that that's reflex, deep, unconscious breathing. This is this is a brain that's gone into a deeply relaxed state. This is not a person who's agitated and uncomfortable. And then death rattle, so important. Our body is felt by our brain when we're conscious, and some bits of it are more sensitive than others. So we know our fingertips, for example, are very sensitive. We know that our eyelashes and our corneas are very sensitive. And another place that's very sensitive is the back of the throat, because we have to be able to look after our airway. So anything touches the back of your throat, you swallow, you cough, you gag, you do what it takes to clear it away. Now, this deeply unconscious person is no longer responding to touch at the back of their throat. They're lying backwards. Any saliva that's in the back of their mouth, or the liquid that we use to keep people's mouths clean and fresh, that kind of stuff, or a bit of gubbins that they've coughed up from the back of their throat, it'll just lie there. It'll be, it's maybe a teaspoonful, maybe less than that. And the air is bubbling through it. So it's not in the way of the air. The air is moving in and out of the lungs absolutely fine, because it wouldn't be a noise if it wasn't moving. But it rattles. That bubbling, rattling is just gas going through liquid. So it makes this weird bubbling noise. And again, we never see unconscious people. We never hear this noise. So it's weird, scary, strange. And one of the things that I found really helpful is explaining to families that's what this noise is. And what this noise tells me, even though it sounds very weird, is that this person who you love is so deeply unconscious now that they are not aware that there's liquid touching the back of their throat. They're just letting it lie there.
Yeah.
And what would you do if you had a bit of tea at the back of your throat? You would not be lying comfortably like that, would you? So we can see this is a kind of helpful sign to tell us this person is beyond feeling the distress of anything touching the back of their throat. But it makes everybody else in the room want to clear their own throat. You can see people going... So actually turning it into a moment of humour, saying, look at you all clearing your own throats, and everybody's coughing and opening the window a bit. Just, we're doing it because we love them. We're doing it because it matters.
That empathy, isn't it? Yeah.
So it's really important to be able to help people to notice what's going on, and to be able to say, look, I've seen this a lot of times. This isn't discomfort. This is safe. This is dying. He's doing it perfectly. He's not doing it wrong. He's not distressed. He's not uncomfortable. He's just deeply, deeply unconscious. And then also, it's a bit like a midwife talking you through labour. They've told you it all ages ago, and you thought you were going to remember it, and now you're in labour and you can't remember any of it, and you didn't think it was going to feel like this. Yeah.
Never goes to plan, does it?
So being able to say, this is that noise we talked about, this is that breathing we talked about, this is that unconsciousness we talked about. And the next thing that I expect might happen is, which like midwife does, it might this, it might be that. And soon one of the things that's going to happen is there's going to be a breath out. That won't be any different from any of the other breaths. It just won't have another breath in after it. And we'll only realise it was the last breath after there isn't another breath. And that's just so not Hollywood.
Yeah.
There's nobody, he's not going to suddenly sit up and tell you where the treasure is buried. It's just going to be a very gentle continuation of what we're watching now.
Yeah. I once had it described to me as it's like a machine shutting down, the last bits where the brain's just still working, just making the body continue, but it's not, there's not someone underneath panicking like, oh my God, I'm dying, what's happening, I can't breathe properly, blah, blah, blah. It's just you're sort of watching the breaths kind of fade out eventually.
In my head I often see it as like a great big country house in the dark, and all the lights are on, and then gradually one by one each of the lights goes out, and it's just a gentle end of life process. We've been designed to know how to die, just like when you have your first baby, you've never done it before, but somehow your body knows what to do.
And it is sad, and it is emotional, and at the end of all of that there is a person that was in your life that isn't anymore. But I love the word gentle that you used, because it doesn't have to be this huge, traumatic, terrifying thing that we should all be scared of. It's it seems quite gentle, I guess.
I started calling it ordinary dying. Really to separate it out from there is extraordinary dying, and we mustn't pretend that it's always fine. That sometimes it's very uncomfortable on the way, and those are the people that palliative care experts often get to meet, because that gentle falling into unconsciousness does get interfered with if you've got horrible pain or difficult breathlessness. So it is really important that early on, maybe that's like the antenatal care, that you get the early part of it right, so that the labour bit runs more smoothly. To get your symptoms well managed in advance is another kind of step on the road towards peaceful dying. But I think the real problem we've got is the publicity and the public awareness that every now and again somebody dies in a way that's been badly managed or uncomfortable, and they haven't had good pain control, and their family is distressed and they are distressed, and afterwards, quite rightly, they complain to the hospital or wherever, they write to the papers, they write to their MP, it gets into the newspapers. And so here's the thing, and I'm talking to two people, one of whom is a little bit worried about flying. Right. Here is the thing.
I wonder who that could be.
We do get on planes, despite the fact that newspapers do not report the planes that land on time, with all their tyres intact, at the right airport, with the same number of souls on board when they land that they had when they took off, occasionally even with your luggage as well. Okay,
Yeah,
that's just taken as,
Yeah,
so the newspapers report true tragedies, right? And it is, if that's happened to somebody that you loved, it's a hideous, tragic thing. But we do still keep getting on planes. And we keep getting on planes because we know that the tragic, though it's true, is like this tiny slice of this massive pie.
Yeah.
And we realise that the slice is almost so small that we can't measure it compared with the likelihood of the plane that we're on falling out of the sky, right? And you can sit there and smile and say, now, but when you're walking up the steps onto the plane, you're a little bit less sure of that.
Just a bit.
Yeah, but nevertheless, when you booked the flight, you did have the sense of proportion.
Totally.
Yeah, so
and then
the
you lose that.
difficulty we've got about dying is that it's that tiny slice of difficult deaths that gets reported. And because we're not used to sitting alongside our dear people while they're dying at home, like we would have been 100 years ago, there was no point in taking dying people to hospital. Hospital had nothing to offer them. So we all understood the process of dying. We'd seen it lots and lots of times. We actually didn't have such good access to painkillers 100 years ago as we have now either. So we would have been much more familiar with it, and we would have known that it was going according to plan. We would have been better at saying, well, hang on, this isn't normal now. Maybe we should get a doctor or a nurse here for this, because this isn't normal. Now we're frightened about everything because we're not used to seeing it. So we need to reclaim our ownership of the rest of the pie to understand ordinary dying, so that we can be less frightened, so we can be better prepared, and so that when ordinary dying goes off-piste and starts to become not ordinary and not right, we can recognise it. Because at the moment I meet families who say, well, yeah, he had a lot of pain, but that's what you expect, isn't it? No, that isn't what I expect. I expect that this pain would have been better dealt with.
Yeah.
So I do book festivals, I do public events, and people come up to me and they bring their books to be signed, which is absolutely lovely. And then they look around, just kind of like, can anybody hear me? And they said, when my mum, my dad, my husband, when my person was dying, do you know, this can sound really weird, but it was kind of lovely. It was really, it was so beautiful. It was so peaceful. And I'm thinking, okay, good. You've seen normal dying, right? Ordinary dying. And then they say, well, we never tell anybody because we know most people have a terrible experience and we wouldn't want other people to feel sad that it was so easy for us. And I'm thinking, so this is another part of the inadvertent conspiracy where we only hear the bad stories, and people who are quietly bereaved in a peaceful way, they're not going to go and shout it from the rooftops, because bereavement's hard work and you want to just go away and do your grieving.
Yeah, and it feels wrong, I think, to sort of be like, no, death can be beautiful and peaceful. It feels societally like we should all be saying, death is a terrible tragedy. But it is, it is a natural part of living. I think also because oftentimes when you have people that perhaps, the people that would end up in palliative care, it's after like a sort of long illness, often seeing people suffering for so long and struggling and coming to terms with everything, sometimes death can feel like a bit of a release, like you're not seeing that person suffer anymore. I mean, I've personally experienced that. And again, even I feel weird saying that, because you don't want to feel relieved that anyone's left your life. But if there's a choice between them leaving peacefully or them surviving miserably, you would want them to leave peacefully.
Yeah, there's a lot of people who experience that kind of the sadness of the loss and the relief of the end of the difficulties at the same time, and then feel horribly guilty.
Yes, yeah.
And yet all of their relief is part of their love for that person, isn't it? And there we are, you see, now we're talking about love. And if we're not good at saying our D words, we're really not good at talking about loving people. That's just like, that's embarrassing.
Yeah,
so we don't go there.
Yeah, some of us aren't. I'm not. Giles is fine on that, aren't you?
I love everybody.
It's very very peaceful, emotional person.
Well, there's a couple of things really. It was interesting you using the analogy of birth and then death with these two ends of the cycle, and it's interesting how actually entwined those two things are. That's just an observation I made. One of the things I was just thinking, obviously, what you're talking about, seeing death a lot, like being involved in death, experiencing, being around people that are bereaved and grieved, and that kind of weight of loss, and how you as a palliative nurse and people in your profession kind of deal with that, because obviously you're talking about like it at times being a positive experience, but at the same time, you're seeing a lot of sadness as well. Yeah. Is there ways for you to have an outlet for that? Is there ways of you coping with that kind of stuff? Talk to me a bit about that.
We get asked a lot about this. Now, you would think I'd have a good answer by now, wouldn't you? And I really haven't. The whole of nursing and medicine is this really broad church, and people find their way to a place that makes sense and that they feel the balance is right for them. So I'm a palliative care doctor. I'm working with palliative care nurses, and largely doctors are not around deathbeds. Nurses are, and there's something very privileged about having been a palliative care doctor and being the person who would get called if things were uncomfortable, or just having the chance to go and see my patients at the very end of their lives was part of what made it satisfying. It didn't make it sadder. It made it more satisfying. Things that would make it sad would be to try and get somebody's pain sorted out and not succeed, or to be working with a family that was very divided and fighting and not be able to find a way to enable them to at least make enough peace for this dying to be a peaceful time for this person at the very end of their life. But I think the balance is that although you're right, it's sad, the highs are so high. You meet somebody they know they've got a limited life expectancy and they got horrible symptoms and they feel completely overwhelmed, and they think, I'm never gonna have a day where I don't feel miserable until I draw my last breath now. And to be able to work with them to get their pain right, to get their breathlessness sorted out, or their itch, or their bowels, little things that make a huge difference to how well or miserable you can feel. And to meet that person up out of bed with their clothes on, going to the school play or something like that, where they thought they were going to be bedbound for the rest of their lives because of their symptoms. There's no sense in the world that's more satisfying than that. So the highs are fantastic, because it's not like I'm doing a heart transplant or doing something that cures somebody and completely turns their world around. But we're turning their world around in a different kind of way. We're able to let them do the things that matter most to them for the time that's left. And we get a lot of people come and work in palliative care, and they're really good, but they can't stay. The balance doesn't work for them. So they will take that kind of expertise in symptom control and the expertise in those really tender conversations around end-of-life care, and they'll take that expertise back to work in, you know, acute orthopaedics or an emergency department, or places where I would find I'd just be overwhelmed by way too much adrenaline. You know, that's not for me. My quietly dying patients, yeah, I can do that. But my friends who work in the emergency department, there wouldn't be enough adrenaline there for them. So it's horses for courses.
You said earlier, obviously, like starting the process earlier is very beneficial, and I wonder if that some of that, giving some autonomy to the patient with regards to how the end of their life plays out, is actually very important. You know, it's obviously discussions around assisted dying and things like that, and I'm not suggesting you go there on that, because that's a very controversial subject. But having that autonomy on your palliative care seems like to be a very important thing to be able to do.
Well, I think the thing about a palliative care approach, which any doctors and nurses can do, or getting the specialists in because this is a little bit more tricky for some reason than usual, is all about person-centred. What matters most to you? How do you want things to be? What can we do that supports your life being the way you want, as close as we can?
Yeah.
So the kind of conversations that I might have, that I talk to medical students about, if somebody thinks that they're getting towards the end of their life, you need to know what matters, and you need to know what's their worst dread and what's their best hope. Because you talked before about isn't end of life hopeless? Well, no, it's not at all hopeless. It's just different hopes. And so you can have that conversation. You know, it's like I meet lots of people who are in the situation that you're in, and I know from that lots of them have a kind of worst dread, sinking feeling inside them of how things might go, and a best hope that they'd really like things to be like. Do you feel you could talk about those things? Because if I can understand what your worst dread is, and if you can describe to me what your best hope is, then the way we can work with you is to try and steer things as far away from your worst dread and as close towards your best hope as we can. And people aren't silly, they absolutely get that. So I remember looking after an elderly lady who had terrible lungs, and she was already using oxygen at home. So when she was walking around at home, she had this really, really long pipe that went out through the window and into a machine called an oxygen concentrator that takes the oxygen out of the air. And these days they're tiny, sophisticated little machines, but in those days it was the size of a dog's kennel, and in fact it was in a dog's kennel to keep the weather off it outside. So she had had the great news that her granddaughter in Australia was getting married. She was so excited. Okay. And before that, we'd been talking about what's your best hope, what's your worst dread. And her worst dread was, you know, horrible breathlessness and being too breathless to speak and say what she wanted. And her most important thing for her was that she just lived not too breathlessly. She said, I don't mind how long I live, Doc. I just don't want to have horrible breathlessness. So all of our emphasis was on quality of life, not length of life. And then the wedding is announced. I will do anything. I will have any treatment. I don't mind how uncomfortable it is. I want to get to the wedding in Australia. Right. If you're already on oxygen at ground level, you are not going to be able to fly at 30-something thousand feet to a wedding in Australia. So we have to think about her best hope is this wedding, and her worst dread is missing this wedding. What do we do that kind of gets that as close as we can? So her granddaughter asked for her granny's wedding photos, and she showed them to her florist, who made her bouquet like her granny's bouquet had been. And then this was all before the pandemic, or before we all got good at Zoom and things like that. So they Skyped her into this wedding. So it's the middle of the night in Britain, and she's got her best dress on, she's got a hat on, she's got flowers. She's at the wedding, except she's not in Australia. And so she came to see me next, and shining, just absolutely so happy. And she said, okay, so now we can go back to the old arrangement. Don't want any difficult treatments. Just don't want to be breathless. Okay. And then the next time I saw her, 3 months later, she was clearly much more frail. I thought, okay, so we can start to see now that she's not just changing month by month anymore. She's changing week by week, which tells us that life expectancy is probably weeks into a few months. Granddaughter's pregnant. I want to see the baby. So now we have to have that conversation about life expectancy and how quickly do you think things are changing? And she knew things were changing quickly. So what can we do that celebrates the baby even if you don't get to meet the baby? So now she's knitting. And she's knitting all of her love into these garments that she's going to send off to Australia. So you can kind of get the essence of what really matters to people. And the hope is changing. The hope to survive becomes a hope to celebrate what is, becomes a hope to celebrate what I'll miss, but I wish I didn't have to miss. The hope to die comfortably, the hope to leave a legacy that's about what's important to you in the world, the knitting, whatever it is. So it's never that there's no hope. It's just that the hope changes. And if nobody has the courage to have the conversation with you that makes it important that you adjust your hope, you'll move towards dying disappointed because you're hoping for unrealizable things. And the kindness of the conversation is the conversation that allows it to adjust your hope towards things that are realizable, things that you can do that really matter to you.
Yeah, and I suppose, would you say that you've noticed something or a difference in patients between those who perhaps have a kind of like a purpose, like, for example, to get to a certain point or to meet the baby or to go to the wedding, versus those people that perhaps have sort of given up all hope and have just kind of haven't really got that purpose or that drive to keep going forward? And I feel like a lot of the time it probably is the family around us and the people around us. Do you notice
I guess do you
that?
have to manufacture a purpose in some...
Well, it reminds me of when we're talking to people like Dr. Ayan Panja, who's talking about having people around you and how loneliness is a killer, and people that don't have that family and again that purpose within that family tend to develop illnesses more often, or whether it be dementia or cancers and things like that. And have you noticed anything like that within patients you work with?
Well, so one of the aspects of depression is hopelessness and a sense of worthlessness, personal worthlessness and purposelessness of your life. And what's interesting is that towards the end of life, that isn't usual. That most people still retain their sense of purpose. So the incidence of depression is a little bit higher in people who are dying than it is in the general population, but it's only a little bit higher.
Wow.
And the treatment of it is the same treatment, which is helping people to notice the discrepancy between their thinking and the reality that they're living, because it's all going to be terrible and I'm not worth anything and it's I'm no use to anybody, versus the wall-to-wall pictures drawn by devoted grandchildren that I'm seeing in your house as you're telling me that you're just a nuisance and nobody loves you anymore. So one of my really great parts of my job was I was a cognitive behaviour therapist as well as a doctor, so I would be doing psychotherapy for mood disorders, and it was so wonderful training in psychiatry, cognitive therapy, where depression took weeks to months to start to lift, and then taking those skills into a palliative care population of patients, and they get better really, really quickly because you're putting them back in touch with their resilience that they always had. And rather than having a depression that's an underlying psychiatric illness, what they've got is just the straw that broke the camel's back thing. And as soon as you help them to take a few more straws off, they bounce back so that they can be resilient about the wedding in Australia or doing the knitting or whatever it is. So most people do find their sense of purpose. And what's really interesting is that towards the end of our lives, it's all about relationships. We're back to love again.
Yeah.
It's not about stuff. It's not about belongings and possessions and money. It's about the things that I treasure in my heart as memories, the people that I hold dear, the difference I might have made in the world. And it's really fantastic to listen to people just reminiscing about the things that have been the pearls in their lives. Wonderful.
Yeah, we've spoken about this a few times on the pod, haven't we? About getting to the end of your life and having regrets versus getting to the end of your life and having, you know, the memories and the friends and the family and stuff like that. And again, we were just talking in a separate interview about priorities and what people's priorities are in life and how that shifts as time goes on. And the pandemic was great for that because it kind of shifted people's priorities slightly and what's important to them. And suddenly everyone, because you can't see your friends and family, everyone's like, what, we need to see them. So they're all Zooming people that they probably haven't spoken to for years and like having quizzes together and stuff like that. And it makes you kind of realise what is important to people.
Yeah, I think that's absolutely true. And, you know, early on in our lives, we think, oh yeah, you know, one of the things that's going to happen is the way I'm going to live my life, I'm going to have no regrets. But actually, if you get to the end of your life and you've got no regrets, then it means you either never did anything or you're a psychopath. You know, that actually the whole of life is comprised of choices where you choose the best thing that it seems the right thing to do at that point. And then afterwards you can judge it. And very often we judge with the retrospectoscope as well. So if only I hadn't done that, but I'd done that instead, my whole life would have been different and better. Of course, you don't know, because 3 choices down that tray, you might have still ended up in the wrong place. But I think what's really interesting at the very end of life is watching people who've had really big storms in their lives get to a place where they're able to say, yeah, I will always wish that thing hadn't happened, that I hadn't made that choice or that horrible thing hadn't happened to my family. But I'm not in that kind of stormy, terrible place about it anymore. I'm in this place called regret, which is the calm version of all those difficult, angry, blame, shame, guilt emotions. So I think regret is our safe harbour, actually, at the far end. And there are 2 sides to the coin. So there's regret on one side and there's satisfaction on the other. All those big, exciting, joyous, momentous things, also they've calmed down so that we're just quietly contented and satisfied. And yes, there are regrets, but they are balanced by all of the things that were okay.
I love that. That's actually a really beautiful way of putting it, because we do perhaps when we are younger and we're kind of in the everyday life dramas and stuff, and the ups and downs, the peaks seem way higher and the troughs seem way lower, and it's up and down, and then you sort of get to this sort of, I guess, would you call it acceptance?
Yeah, I think what happens is we become wise. I think it's wisdom. I think it's that place that says, yes, you young people, and by that I think I mean emotionally young, because I've looked after dying teenagers who were emotionally aged and wise, but looking at people who are still caught up in the storms, and they are able to get to a place that says, in the end, the only thing that's constant is now, this very moment. And they've discovered mindfulness for themselves. They've discovered that there's only the now, and the whole of time is kind of rippling past now, and I'm always in now.
Yeah, what a shame that it gets to that point when it's kind of near the end, when we finally get to that place of mindfulness. Would you say that do you think it's because people tend to have more of a sense of perspective when you're going through something like that?
I think there's nothing like thinking this is going to be over soon to really help us to understand that everything always was impermanent. You know, nothing was ever guaranteed, and stuff is stuff. The things that are precious, that are wrapped inside us, are all about emotion and belonging and ties. They're not about stuff at all. And the other thing that's really interesting is even when people are in really deep suffering, whether that's physical illness or whether that's bereavement and grief and that kind of brokenness, whether it's the stage of labour where you think you're going to break in a minute, you know, whatever it is, you can always get through what is happening right now. And I think people learn eventually to be able to see life as a series of nowness. And if you step back and look at the bigger picture, it might seem too terrifying. So if you just bring it back down to now, just breathe through now, that's copable with. And it's really interesting watching people kind of discovering that for themselves. So gurus and meditation teachers, they can get to there. It's fascinating.
Wow, that's amazing. Yeah, it reminds me of when for some reason I was like terrified of getting COVID. I was like, just constantly throughout 2020 and 2021, I was like, like washing my hands and just making, because for some reason in my head,
you washed your hands. Oh my God.
I know, I washed my hands for once. I was just convinced that if I got it and I got really ill to the point of like hospitalization, you know, because I live alone in the woods, I was like, no one will find me and I'll just die on my own or whatever. And then when I got it, it was really bad and I was fine, and I was just like, you know, watching Netflix, texting my friends like, oh yeah, I've got COVID. And one of my best friends was like, isn't it funny how like terrified you were of getting it and then you get it and you don't care? I was like, it's actually a really good life lesson that we go through life constantly living in the future, worrying about things, and living in the past, regretting things, and the now is never that bad, really. Yeah, it's fascinating.
Yeah, you're absolutely right.
I think we all need to learn to live a bit more like that before
present is very, very important. Just to finish, it'd be great to talk to you a little bit about, I mean, you've written several books, but with the end in sight, tell us a bit about writing that, how that came about. What?
That was all a bit mad, really. It was all very unexpected. So I'd take an early retirement to think about what I might be able to do about the public misunderstanding of dying, and I wasn't quite sure what I was going to do. I just knew that while I was still at work running around that hamster wheel, I wouldn't work it out. And I knew that my grandmother understood dying from the inside, because she had lived all that time ago when people died at home and were looked after by their young female relatives, their fit female relatives. So I knew that what we're missing is seeing it over and over and over again. Well, there must be ways of showing people it over and over and over again. Could we change soap opera plots? Could we get things into, I don't know, magazines or newspapers? I didn't really know. And then by coincidence got invited to speak about dying on Radio 4, on 1 to 1. And the episode was heard by a literary agent who got in touch with me and said, I heard you tell a story, and have you got any other stories? Have you ever thought about writing a book? And as he said it, I thought, of course that's how you do it. Yeah. But how do you do that then? So I had this really strange experience of moving from being quite a senior consultant in a well-recognised institution, knowing which way was up and how you did things, to becoming almost like a newly qualified doctor all over again who doesn't know anything, writing a book. So I knew that I wanted to tell stories that help people to feel familiar with the usual things that I get asked about when I first meet families in my clinic. They're worried about what will dying be like. Does morphine shorten your life? No. What do we tell the children? Is home or hospital or hospice better? Those sorts of things. So I just sat down and wrote these stories, and it almost sounds fantastical to me now, and I try and explain it. But something completely strange happened where I would sit down and think, I need to tell the story about that day when I didn't know what to do with that girl who just couldn't settle down because she was having a bizarre reaction to her anti-nausea medication, and that was such an interesting thing that happened. I need to tell that story, and that would be breakfast time, and I'd have a cup of tea in front of me, and then the sun would be setting, and I'd have a scummy cold cup of tea next to me, and there was a story on my laptop. And nobody else had been in the room, so I must have written it. But it felt like almost discovering the stories. And I've subsequently heard other people talking about writing or painting or, you know, that kind of creativity. But it hadn't been a thing that I'd come across before. So the book kind of wrote itself. And I suppose you could say it took it took a year to write, but on one level, I suppose it took 40 years to write.
Yeah.
And then I thought, well, you know, I understand spelling and punctuation. I won't disgrace myself. It'll be in a few libraries, and I give a copy to my mum and dad. They'll be proud. I had no sense at all of what was going to happen next, of this massive national, international response. I still feel like all of that is happening to somebody else. It's extraordinary. And what's really wonderful is practically every day, but certainly several times a week, I get a message from somebody who's found me on social media, found my agent, written to a newspaper that's had an interview with me. People are really, really creative, just to say, this changed my understanding of what was happening to my person. And the first time it happened was 5 days after the book was published, when I was still feeling anxious that I'm telling real people's stories. And of course I couldn't get their permission because they died, and I had no notion of writing their stories before. And I got a message through a message request on my personal Facebook page, which wasn't a thing that I even knew could happen, from a woman who said, I wanted to thank you for your book. My mum died 10 years ago. I was with her. I watched her. I thought she was drowning. I thought she was choking. She was making the most terrible noises, and her breathing was dreadful. And I couldn't stop hearing it. And after about 2 years, my GP diagnosed post-traumatic stress disorder, and he sent me to a therapist. And I've been in therapy for, I don't know, 5 years or 8 years or something like that. And yesterday I read your explanation of ordinary dying, which is actually a story in which my first boss in a hospice is explaining to a patient what dying is going to be like. And I've been allowed to come and listen, and I'm completely horrified that he's trying to describe actual dying to an actual dying person. Like, you can't do that. So self-righteous and knowledgeable, 26 and knowing everything. And it was such a game changer for me to listen to him making this description and think, oh my God, that's right. How had I never seen that before? Because I've seen it so many times, but I didn't realise it was actually like a process, like birth is a process. And you can tell people, and they feel like she felt, which is completely calmed and ready. Wow. So this woman wrote and said, I read that story last night, and last night I slept through the night for the first time in 5 years. So once I dried my eyes, I thought, you know what? If for nobody else, it was worth it just for that. But I get messages like that still, and it's years now. It's 8 years since the book came out.
I mean,
beautiful to hear.
Yeah, you're a doctor, so I won't get too spiritual with you. But I do believe that sometimes things like that they're meant to happen, And you felt called to do that and called to get that out into the world and to write the book, and you did. And now you've changed so many people's lives. Funnily enough, we were actually talking to a lovely woman called Sarah Tarlow on this pod. She was talking about her husband's passing away, and we were discussing the fact that there's all these books like for new expecting mothers, like what to expect when you're expecting, stuff like that. And there aren't any books about what to expect when you die. Well, there weren't any books about what to expect when you die, but there were these books in centuries gone by. They used to have these sorts of things as like a what to expect, everyone gathers around your bed and blah blah blah. And we were saying, it needs to be more spoken about. It needs to be explained to people.
It absolutely does. And one of the original books was the medieval Ars Moriendi.
Right. Yeah.
Okay.
Yeah.
And that's almost like a comic, because obviously the population wasn't literate, so they're all drawings. But one of the things I love about there's a version of the Ars Moriendi, so that was all about how to have a good Christian death. So because that's what it was all about.
Right.
So in each picture there is a devil tempting the person to do a particular deathbed sin, and then an angel helping them to resist the devil. But what's really interesting is they're exactly the same things that we see now of the people who are distracted by money and stuff and business, or now it might be social media and number of likes and things like that. You know, distracted by that and not being with and alongside and present and now with the people who matter the most to them.
Yeah.
So human nature, you know, hasn't changed in all of those centuries. But we do need to know, and they did have manuals to help them, because believing that you were dying in a godly way in medieval times was reassuring. And, you know, if you can die in a simple and comfortable way with whatever spiritual perspective you bring to it, because I don't think it has to be religious, but meaning is a spiritual dimension in our lives, isn't it? And it's really important to people that they complete their circle of what the meaning is about.
Absolutely. I mean, I found it really helpful talking to you, just from my perspective, you know, just for me personally, and I'm sure the listeners will as well. But, you know, I've had experiences of watching a loved one die, and it wasn't in a hospice and it wasn't in a palliative care unit, and there weren't any nurses or doctors or anyone telling you what was happening. It was, you know, completely on your own. You watch it happen, and then they're like, here's a pamphlet about bereavement, and then off you go. Nothing was explained. So actually I found this quite helpful, you know, similarly to the woman that you were talking about who messaged you about that. You do look back on these things and you're like, I wonder what that meant and what was happening there and stuff.
So we need more of us, don't we? Just ordinary people just saying, look, I've seen this before. One of the things I really love is that there's a grassroots movement now of end-of-life doulas.
Oh yeah. No, but I've heard they were quite common in America, I think, at one point, but more in like hippie circles and stuff. But I think they're becoming more common.
Sounds like a great idea.
Yeah, so there's proper training now, and they've got a certified diploma level training. I'm their patron.
Oh, that's awesome.
UK, I'm their patron. I'm really proud. But that's, you know, people from all walks of life doing their training so that they can be your friends or neighbours who can just sit there and go, oh yeah, that breathing, you don't need to worry about that, that's what happens. And you know, the next phase it will probably be a bit like this, and you might hear this and you might hear that. If it's different from that though, give me a call, I'll just come back, I'll have a little look with you. Because my nana in her late 90s had said to me, you know, I want to talk to you about I'm a bit worried about what might happen while I'm dying. And I thought, I'm going to be able to help my nana. Isn't that nice?
Yeah.
And so I started to talk about what dying is like. And she just looked at me like, you know, I taught you to use a spoon. I'm not worried about doing the dying. I've seen that. I know that's not the thing to worry about. So first of all, how fantastic that she'd seen it enough times that she could say, I know that's not a thing to worry about. What I'm worried about, she said, is I don't think your mum and your auntie and uncles have ever seen a person die. And that was like a real light bulb moment for me, because I suddenly realised, do you know what? When I was first qualified as a doctor in the early 1980s, my elderly patients understood dying because they were her age. And they'd seen it and they were not worried about it and they knew what to expect. But the people around their beds didn't. And now they are our elderly people and there's nobody left who remembers. Yeah. So somehow we've got to put it back. And that's what I love about the doula movement. That's what I love about the compassionate communities movement, that we're starting to say to people, this isn't medical knowledge, this isn't nursing knowledge, this is just being human.
Yeah, human nature.
And if we all know it and we can all share it with each other, then we can all be there for each other and we don't have to medicalise it. This is such a personal, intimate time in your life. We shouldn't have it kidnapped into hospitals or even hospices. We should be able to be where we want to be with people who are not terrified because they don't understand. Able to just be our companions with good symptom control to our last breath.
Absolutely.
Oh, Kathryn, thank you so much for your time today. It's been so lovely to talk to you. It's been it's been a very compassionate conversation. So thank you.
Lovely to be here. Thanks.
Really important conversation as well. Thank you.
I'm going to put a tissues warning on this one.